All right, so any questions from previous lecture? Cover kind of the beginning pulmonary stuff. We're going to finish up talking about our antibiotics and whatnot here, and then we will move into the next pulmonary section if we have time and talk about my asthma management and the COPD and stuff like that. No questions? Okay, so have you guys covered pneumonia yet? Anything about pneumonia? Okay, so we'll look at some of the antibiotics and stuff we're going to be using in pneumonia. So again, we have several varieties of pneumonia. Certainly we have community acquired. What other varieties can you think of? Hospital acquired. And what can you kind of break? What's another kind of version of hospital acquired? Ventilator acquired. Yeah, absolutely. So it's important to make that distinction there because the antibiotic management will differ because what's kind of the difference between these different varieties of pneumonia? Resistance risk is true, that changes. What else? Even the types of bugs that are going to be possible, right, or they're likely to cause infection here are going to be different. So that's why we want to make sure we're covering these appropriately, and this is why our antibiotic selection is going to change based on the type of pneumonia we're dealing with. So we'll look at that, and if on a test, it came up and it said, hey, you have this community-acquired pneumonia, or someone's coming in with no past medical history, what are the most likely bugs that have caused this? What antibiotics kind of go with that? Those are the thought processes you're kind of going down. So certainly we have a pretty decent normal pathway for kind of protecting the lungs from infection. Because normally, if you think back, deep down in the lungs, is that typically is there a lot of bacteria down there? No, it should be sterile for the most part, right? So, and this is important that we have these defense mechanisms, right? So you have these kind of ciliated epithelia, which are going to kind of be constantly moving things up through the respiratory tract, where you can eventually expectorate out this mucus. We're kind of trapping all those kind of debris and bacteria and things like that. And again, you can have issues where this can be uncoordinated. You have paralyzation of these cells. Also, what kind of patients could kind of do chronic damage to these cells over time? Yeah, smokers for sure. So you can see damage to these cells. They can eventually lose the cilia, and then they're less able to kind of get rid of a lot of that gunk and things like that. And it's not just cigarette smoke, tobacco. Certainly, you can see issues if patients are smoking other things, because typically that gas is really, really hot when you're smoking things like you see this with cocaine patients, people smoking crack. You can see this with people who smoke marijuana chronically. All of that kind of hot gas can really damage those cells, and also leads you to other disease states like emphysema, right? But what else can you, if you're kind of chronically damaging those cells, what can you see develop? Bronchitis, COPD, sure. What else? Cancer, yeah, cancer is the other big thing. So that's kind of what we're shooting for there. So anywho, certainly, how do we get bugs into the respiratory tract? Oftentimes you can find that depending on the type of patient, depending on how well protected their airway is, you can have aspiration of bacteria from the oropharynx. And so that's going to be more common in elderly patients, especially those that maybe have kind of depressed mental statuses. We see this a lot with patients who are, say, on medications that can depress the mental status. So if you think about alcohol, you think about benzodiazepines, anxiolytics and things like that. They're not protecting their airway particularly well, and so they can end up aspirating bacteria and things. You also have inhalation of infectious aerosols. Potentially, you could have this hematogenous dissemination. So if you had kind of a bloodstream infection, that could potentially move on over into the lungs. And then sometimes you can have actual direct inoculation, which is usually due to things like trauma, probably the less frequent one. So as far as symptoms go, you guys have covered. Not really haven't covered pneumonia yet, but you guys will learn kind of the classic signs and symptoms. But oftentimes you're going to have a lot of cough, fever, a lot of sputum production, dyspnea potentially, and then typically you'll have your lung exam. It'll just sound kind of gunky, right? Now, occasionally, depending on your patient, you may have some other issues. Chest pain may pop up. You may have things like mental status changes. But it, again, depends on how old or young your patient is. Depends on other concomitant disease states, etc. Obviously, our gold standard is going to be chest X-ray to make this diagnosis. I'm obviously no expert on reading X-rays. If the pharmacist can tell you that someone has a pneumonia, it's pretty bad. So like something like that, I'd be like, yeah, that looks bad. It's probably something bad. But you guys will be much more well versed than me for sure. But again, in some cases, you may find that patients may actually have a normal chest X-ray, and even though they do have the presence of pneumonia, because again, what's kind of causing a lot of this kind of whiteout here in these areas? Obviously, this is an immune response, right? You're having a lot of inflammations going on there, causing a lot of damage to the tissues. And so that's kind of where you can see a little bit of that. And so patients who may not have a good immune system may not be able to mount any kind of response, may look relatively normal. So just kind of keep that in mind when kind of discussing X-rays. But regardless, we're going to be more concerned about how we actually treat this. And again, typically with these community-acquired pneumonia patients, you can, one of the big decisions you have to make is kind of treat them outpatient versus inpatient. You guys ever heard of any of the scales that we use to make that decision? We'll talk about a few of them a little bit later, but basically we have these scales that'll help us to make a good decision. Because again, some patients might be just too sick to send out on outpatient care. They may require things like IV antibiotics, but for some patients, typically they do pretty well with empiric antibiotics. And again, what's the best way to get a culture from the lungs? So what's the matter with just using sputum? So if I just hack up onto a agar plate, what's the problem? Yeah, you get a lot of spit. So again, one of those things, if you ever see a lot of epithelial cells in your culture, that typically is or in your specimen, that typically is indicative of spit. Because again, the things in your mouth are not necessarily what's causing disease down in the lungs. So the gold standard for getting a culture would be, has anyone ever heard of a BAL or bronchial alveolar lavage? Basically, they stick a tube down your throat. The patient's typically intubated in these kind of cases, and they'll put an amount of water, saline, or something down into the kind of deep parts of the respiratory tract, kind of wash that out, and then collect that back. And then that's right where the bacteria are. You have a better idea that's actually what's causing disease. So a lot of times people will get sputum cultures, but it may not really be indicative of what's causing disease. So you always want to take that with kind of a grain of salt in those cases. Routinely, that we don't have to do cultures on these patients. They'll do well with empiric antibiotics, and you really don't need a whole lot of further diagnostic testing unless they fail therapy or they tend to get sicker. Now, if they do have, if they're going to be coming inpatient, typically that's when you do want to get cultures. Sputum cultures can be useful here, but also you want to check potentially for blood cultures because again, you want to look for any kind of hematogenous dissemination there. And again, why do we do this prior to antibiotics? Because if you give antibiotics early, you may actually start to wipe out those bacteria and you may not get a positive culture back, right? That's one of the things where timing can be really important. This is important for meningitis, important for pneumonias, sepsis, all this stuff. You want to get your culture done prior to antibiotics. Otherwise, you might start to wipe out those bugs and you get a negative culture back and you're not sure, was it truly negative to begin with, or did I just have antibiotics on board and I could not culture out those bugs? So keep that in mind. Again, obviously, there's something where, getting antibiotics, getting the culture beforehand would put a kind of really long strain before the patients could get antibiotics. That's not really okay, but in general, you can find that you'll get the culture first and then antibiotics. Now, the first thing you look at is you'll get a gram stain culture on the sputum. Again, as I mentioned, that expectorated sputum frequently is contaminated with a lot of stuff in the mouth. You mentioned what type of bugs are in the mouth? Yeah, you can see a lot of anaerobes and things like that. They're kind of growing in the mouth. So again, those are going to be more difficult to culture out, but again, those usually aren't causing disease. Hold on 1 second. So anyway, talking about gram stains being potentially contaminated, and again, not always responsible for showing us the pathogen that we're actually curious about. So again, I mentioned site of treatment. So depending on several things, we have different scales that we can use, things like the CURB 65 or the Pneumonia Severity Index. This will help us to determine, I'm not going to go in depth on these, you'll learn those in your pulmonary section, CMS. And so basically, these will help us to determine, based on how sick the patient is, depending on things like their respiratory rate and other symptomatology, like do they need to come in or can I treat them on the outside? Obviously, outpatient therapy is going to mainly comprise of a lot of oral therapy. If they're going to be coming in, that's usually they're severe enough where I'm going to have to require them to receive IV or parenteral therapy. And again, some of these scales will tell you, do they need to go to the ICU or can they just go to a regular med surg floor, right? So again, looking at the severity, it'll kind of guide you to make sure you're placing your patient very appropriately in the hospital. Okay, so more importantly, what's our etiology here? What are the common bugs that are going to be causing disease here? And so again, depending on the type of bacteria it is, they are kind of associated with a particular type of severity, essentially. A lot of outpatient bugs, you're going to notice these are pretty similar to what we've seen somewhat previously. You see things like strep pneumo, see things like Moraxella catarrhalis. Obviously, there's going to be some subset of this as respiratory viruses. But what do you kind of notice here? What type of bug is that? Atypical, right? So you worry about atypical bugs here as well. You start to think about atypical coverage when you start to think about some of these pneumonias, right? So that's kind of one of the big differences between treatment for things like, otitis media or these other kind of upper respiratory tract infections versus a pneumonia. Start to more think about atypicals being responsible here. Again, H flu as well being seen with outpatient. On the inpatient side, and this would be non-ICU, this would be patients that are sick enough to require hospitalization, but not sick enough to really get into the ICU. And so again, you're going to see things like strep pneumo, mycoplasma, possibly chlamydia here, H flu. This is when you can start to also see things like Legionella. I actually talked a little bit about that in the first epidemiology slides, which is now posted. So check out my YouTube channel. No, I'm just kidding. You guys remember where I mentioned where Legionella got its name from? Yeah, from the hotel. The American Legion was having a convention, right? So again, you can see interesting kind of origin for some of these names here. Again, and also you were about aspirations. When I say aspiration, I mean obviously stuff from the GI tract. What type of bugs would you think about coming from the GI tract? Yeah, think about gram negatives, right? Kind of more broadly. What else could you possibly see? Possibly Enterococcus. Kind of more broad, like instead of so like we have gram negatives, some enterogram positives potentially. I would say that kind of other thing. Anaerobes, yeah. So we're about anaerobes. So I will tell you though that in a lot of cases, patients will be put on coverage for what they call aspiration pneumonia. One of the big problems with that is, the patients say they aspirate and you worry about pneumonia. The thing is like when you aspirate stuff from the GI tract, like it's a lot of like, bile salts or bile acids and just stuff from the GI tract and, those normal gastric acid and things like that. Like, what do you think that does to the lungs? Is it particularly healthy for the lungs? No, it's going to cause a very similar reaction to what you can actually see with a lot of the bacteria here. So when you hear like an aspiration pneumonia, a lot of times what we call that is a pneumonitis essentially. We're having inflammation, but it's not really due to an actual infection. So be careful. You'll learn more about this, but be careful when you see people that are trying to treat aspiration pneumonias. A lot of times they're not actually bacterial in origin. They're more just kind of your body's response to that kind of chemical irritation from stuff in the GI tract. But anyway. Right, so you're worried about atypicals here. Again, you're worried about kind of similar stuff, aspiration being a potential risk as well, especially a lot of older patients. And then finally, when you get into the ICU, these are the sickest of the patients. You're going to start to see more kind of virulent gram positives and gram negatives. This is when you start to worry about Staph aureus being a problem here, a lot more gram negative bacilli. This is where Pseudomonas can be starting to make an appearance here. And so you'll see based on where the patient's at, for outpatient, inpatient, or ICU, our antibiotics we're going to choose are going to differ a little bit. Okay. Obviously, the biggest guns, the most intensive regimens are going to be required for the ICU patients because obviously they're the sickest. So factors that can make you more susceptible to specific infections or specific pathogens, I should say. For patients who are more at risk for having penicillin-resistant strep pneumo, age greater than 65 tends to be more likely to have resistant strep pneumo. If they've received any beta-lactam within the past 3 months. Right, so beta-lactams I'm referring to what? Penicillin, cephalosporins, right? Those are the primary ones. So why do I say that? Why in the past 3 months any beta-lactams? Yeah, worried about you select it out, you put selective pressure on these bacteria, you're more likely to see a resistant strain kind of rear head. Alcoholism, what do you think that is? Can have some depression of the immune system for sure. What else? What did I mention? If you depress your mental status, what else can you see? Possible aspiration, right? So these are all little things that can make you more likely to have some of these resistant bugs. If you're immunosuppressed, obviously that can be one big thing there. And then medical comorbidities. So typically, the more comorbidities they have, typically the more likely they have some of these resistant strains. So things like diabetes, renal insufficiency, CHF, coronary artery disease, all kinds of different things that can make you more likely. And then also wide exposure to a child in a daycare. Because those places are cesspools. They are disgusting. Right. And so like it's basically like if you were trying to like weaponize like strep pneumo, like you just go to a daycare center and like just swab any of the children and you'd have a really virulent strain. So again, if they have exposure to kids in daycare, like you tend to be more likely to see a resistant strep pneumo. Because again, they're on tons of antibiotics anyway, so then they're going to be passing it back to grandma or mom or dad, whoever happens to be. So people at risk for enteric gram negatives, if they have a residence in a nursing home, a lot of times you will consider people coming from a nursing home almost like being in a healthcare setting. So this is almost going to be like a healthcare acquired pneumonia is what we're going to see here in just a little bit. Underlying cardiopulmonary disease, any kind of medical, other, like kind of the list we were looking at before, diabetes, CAD, things like that. Then obviously recent antibiotic therapy, again, kind of predisposing them to having some of these enteric gram negatives. And then Pseudomonas, any kind of structural lung disease, corticosteroid use. Why do I say corticosteroid use? Immunosuppressive. Any kind of broad spectrum antibiotic therapy for greater than 7 days in the past month. Again, because we're selecting out for those resistant bugs. And then malnutrition tends to suppress the immune system and make them more predisposed to Pseudomonas. Okay, so as far as management for these outpatient pneumonias, again, if they have no risk for resistant strep pneumo, we're going to start to use our macrolides as first line. So typically, we're going to either shoot for azithromycin or clarithromycin. And so again, what do you notice about the macrolide coverage of bacteria? Atypicals, right? That's one of the big things that's nice about the macrolides. They can cover atypicals, so you can go ahead and, if you're not really worried about strep pneumo, it'll still get some of those strep pneumos, but it'll also cover your atypicals, which is a good thing. That's what we want to cover for. Notice second line, we can use something like our tetracyclines, like doxycycline, minocycline, if they had a particular allergy or if they could not receive macrolides for whatever reason. So that's kind of your go-to. And then if they are at risk for having a resistant strep pneumo, so they meet any of those criteria we talked about before, that's when you're going to add on and use double therapy, right? Again, we typically do not like to use double therapy, but sometimes it is warranted. And so again, we're using our macrolides to cover for atypicals because does amoxicillin, clavulanic acid, or Augmentin, does it have coverage for atypicals? Not really. We're really using it for that resistant strep pneumo, okay? So this is when you can utilize either your Augmentin, cefuroxime, or cefpodoxime. So again, a second or third generation cephalosporin would be fine here. Ceftonir would be a good option as well. So any of those are okay. Or potentially you could utilize, so again, you'd use that in addition to azithromycin potentially, or you can utilize what we call a respiratory fluoroquinolone. The big two that we use for that are going to be levofloxacin and moxifloxacin. So you could use basically the fluoroquinolone by itself, or Augmentin plus a macrolide, okay? So kind of want to make sure that the distinction is clear there. Again, that could be good for patients who cannot tolerate beta-lactams for whatever reason, okay? But again, overuse is a problem, so we're starting to see resistance to our fluoroquinolones, so I like to hold back on those as much as you can, okay? Remember what we said you cannot use moxifloxacin for? Yeah, UTIs, yeah, because again, it doesn't get into the kidneys at all, so it's going to be liver metabolism. Good. On the flip side, they're going to be on the inpatient side, non-ICU. We can utilize a intravenous beta-lactam, so we can use something like cefotaxime is a good third generation. Ceftriaxone is another good common one. Again, it's nice because it's only one time a day dosing. Or you could use something like high-dose ampicillin. Ampicillin, high dose intravenous. You don't necessarily need to jump to adding on a beta-lactamase inhibitor because by getting it at those high concentrations, you can generally overcome that resistance to strep pneumo. And then plus either an intravenous or oral macrolide. I will tell you that for the most part, you're going to stick with using an oral macrolide. Like azithromycin is probably the easiest one to go with. IV macrolides don't get a ton of use, and they're generally a lot more expensive. Okay. So, or you could utilize doxycycline as a replacement there, or respiratory fluoroquinolone. So again, they had a beta-lactam allergy, that could be a decent alternative. Okay. If they're in the ICU, then you'd either use the same as the above, but again, all IV treatment, so you wouldn't want to start them off on oral. They're sick enough to warrant ICU stay. And then you need to consider MRSA coverage, right? So again, if you think about MRSA coverage, what could I use? Vancomycin is the go-to, yeah. So 9 times out of 10, you're going to use vancomycin. What could be another decent option? Clindamycin is probably a good backup, right? So if they couldn't receive vancomycin, clindamycin might be a decent option, as again, these are going to be really broad spectrum gram-positive killers, right? But usually vancomycin is going to be our go-to. So again, looking at community-acquired MRSA, we're starting to see a higher incidence of this, and you want to suspect this if you have patients, if you say notice on the x-ray you had these cavitary infiltrates, and they didn't really have any risk for aspiration. That could be one reason for it. Or if they've recently had the flu, these patients tend to be more likely to develop these community-acquired pneumonias, or MRSA, I should say. Yes, ma'am.
I'm sorry, on the last slide, I just want to clarify, so you either use ceftriaxone plus an oral macrolide, or just doxy by itself?
You could utilize the doxy as kind of a replacement for the macrolide. Yeah, typically, I don't see a ton of doxycycline used on the inpatient side, though. Typically, the fluoroquinolone would be by itself, actually, at that point, yeah. Unless you had any kind of like documented resistance to where you were sure that you needed to add something else on board. That's one of those things where, you know, like I said, Levaquin can be a really good IV agent. I don't see a ton of tetracyclines being used on the IV side, but occasionally you can see it being done. Yeah. Okay. All right, so again, you mentioned if you have high yields of gram-positive cocci and clusters on the gram thing, again, that would also kind of trigger you to think, hey, Staph aureus, and that will either require usually vancomycin. Lynnaes could also be a decent option here as well. Again, vancomycin is usually the go-to, but if they couldn't receive that, Lynnaes could also be used, right? All right, so then talking about our nosocomial pneumonia. So again, these are going to be ones that are associated with the healthcare, so either hospital-acquired pneumonia, ventilator-acquired pneumonias, things like that. HCAP would just be healthcare-acquired. Again, these are going to be infections of the lung that are not present at the time of admission. Okay, so these people that come in maybe for another reason, but then they develop pneumonia, typically greater than 48 hours after admission, and this is going to include all this kind of umbrella of different types of hospital-acquired type of pneumonias. Now, the reason why this is a big deal is because, again, if you come in, say, to have, like, say, a knee replacement and you end up with a pneumonia, how much do the insurance companies want to reimburse you for that? Nothing at all, right? Because they say, well, why'd you let them get infected, right? So this is why infection control is super important in hospitals. This is why you're seeing a lot bigger role in this because, again, people like Medicaid, Medicare, they're not wanting to reimburse for this. And if they don't do it, a lot of other insurance companies tend to follow suit in a lot of those cases. Because, again, you get what they call like a diagnosis code or like a DRG. It says, like, hey, you're coming in for a knee replacement. This is how much you get to take care of this patient. If they come up with a pneumonia, well, that's on you, right? This is why these are kind of money losers and why we want to make sure that we prevent these as being the best thing rather than having to actually treat it. So anyway, again, second most common infection in hospitalized patients after UTI. Those tend to be a little bit more common. And again, we're going to see this much more in elderly patients and those that are mechanically ventilated, right? Because again, why do you think mechanically ventilated patients tend to be more at risk for these type of pneumonias? Have a big plastic tube right into their lungs, right? So again, we are giving the bacteria a perfect vector in order to get into the patient. We kind of anytime you're adding hardware to a patient or inserting hardware into a patient, that is a perfect way for bacteria to get involved, right? So why do you think UTIs are so common? Catheters, absolutely. So again, indwelling catheters tend to be another really great way for bacteria to get in. Okay, again, higher mortality, higher hospital costs is why we like to prevent these. Okay, so again, these healthcare-associated pneumonias would be those in patients that are meeting the following criteria. So these are the ones you consider having a healthcare-acquired pneumonia or associated pneumonia. Those are in the facility greater than 2 days in the past 90 days. So again, if a patient, say, showed up at your ER and they had any of these criteria, this would be, again, indications would be a healthcare-acquired pneumonia or associated pneumonia. If they're coming from a nursing home or like a long-term care facility could be another one. They've had recent IV antibiotics, so put them at risk for this. Chemotherapy, because again, that tends to be immunosuppressive, absolutely. Wound care, like wounds can get infected pretty easily, and then hemodialysis patients. What do you think that is? Yeah, that could be one way. All right, so hemodialysis patients are typically they're going to go in Monday, Wednesday, Friday into their hemodialysis clinic, and they're around a bunch of other people who maybe have some bugs that can spread to them. Also, if they have a dialysis catheter that is kind of a permanently, or not permanently placed, but one that is in place, so that way they don't have to get dialysis catheters are kind of central lines, or kind of similar to central lines, in that they're a lot more invasive. So usually you put one in and then you kind of leave it there for a little bit. Again, those are more likely to get infected, and just in general, dialysis patients tend to have a little bit more suppressed immune system than an otherwise healthy patient. So again, all those things make them more at risk for having these infections. Okay, so again, we look at risk factors for these nosocomial pneumonias. Some of them are going to be modifiable, some are we consider non-modifiable. So unmodifiable are things we cannot change about the patient. So we cannot change their age, they're greater than 70. We cannot change if they have chronic lung disease, things like COPD, emphysema, things like that. Depressed consciousness, right, unless we made them have a depressed consciousness with drugs or something. Large volume aspiration, and then hospitalized during the winter months, right, because again, people tend to get viral infections. It also kind of sets the stage for bacterial secondary infections and things like that. As far as modifiable, though, if we can get them off the vent faster, that is a good thing. We always want to get patients off as soon as we can. They're on an NG tube. Get rid of that, right? If they have an ICP monitor, anyone know what that is? So you can tell if your patient's turning into a juggalo or not. Anyone? That's not insane clown posse reference. That is an intracranial pressure monitor, right? So if you had a patient who, say, was coming for a head injury and they had cerebral edema that was forming and they need to put intracranial pressure monitor, again, that's hardware that is indwelling in the patient. That makes them more likely to see these infections. Now, this is interesting. We have H2 blockers or antacid therapy. So we talked about H1 blockers. What do we use those for? Antihistamines as, what do we use them for? For allergies, yeah, I typically use them for allergies, or if I had like an allergic reaction, you could use those. H2 receptors are primarily found where? In the stomach, right? Those are really responsible for kicking off a lot of gastric acid secretion. So if we block that, or if we're giving antacids, what would that do to stomach acid? It would neutralize it, right? Because again, we're giving things like calcium carbonate, sodium hydroxide, etc., that will neutralize the acids like an antacid. So why do you think that would make someone more likely to see one of these kind of nosocomial pneumonias? Because the pH of the stomach is usually around what? Yeah, it's like pH like 2, right? It's pretty difficult for bacteria to grow in that kind of environment. If I start to neutralize that, if I raise the pH, all of a sudden you have bacteria growing, and now they can have more likely to have bacteria aspirate. You see that spread there. So that's one of the risks. And also one of the problems, though, is you have a patient who's in the ICU. They're usually in a very stressed physical state. That usually means that their corticosteroid production is what, up or down? Typically up. And that typically does what to your, it's anti-inflammatory. You're decreasing prostaglandin synthesis. What do you think that does to the stomach? Yeah, less mucus, less of that protective barrier. So one of the risks you run into with having these patients who are really chronically stressed is you see these stress-induced ulcers, right? So you can see gastric ulcers that happen. So very frequently we're putting patients on things like proton pump inhibitors. We're putting them on H2 blockers in order to make sure that they're not rotting through their stomach with having that diminished barrier. So now we're on this double-edged sword, basically, where we want to make sure patients don't have these stress-induced ulcers, but we also don't want them to aspirate and have a pneumonia. So this is one of the big things we worry about with our patients, especially those in our ICU for a prolonged period of time, because again, you have to do kind of both, but there are things we can do to kind of manage that. Okay, obviously previous antibiotic exposure, again, making more at risk for having these type of pneumonias and their reintubation. Okay, so looking at when you have a nosocomial pneumonia, kind of the normal gram-negative bacilli you're more likely to see. Again, Pseudomonas tends to be one of the more common ones you're going to run into, right? As we said, this is a pretty nasty player here. E. coli, Klebsiella, Acinetobacter, Enterobacter, and Serratia are going to be kind of the more common gram-negative bugs you're going to see here. And then as far as gram-positive go, MRSA tends to be more common, with strep pneumo kind of being behind that. And then the other thing is you have to consider, if you're giving your patient kind of broad spectrum antibiotics for several days, they're not improving, you have to start thinking about other types of organisms, right? You have to start thinking about things like mycoplasma, like things like tuberculosis, which may be causing disease potentially, or things like fungus. And so that's why you need to make sure you are considering that. You have to do the appropriate cultures, and we'll learn that those take forever to come back anyway. So a lot of times they get put on kind of empiric antifungal therapy if they're not really responding well to antibiotics. But things like Candida, aspergillus can start to show up here. Again, who else do you think is more at risk for fungal infections? Immunocompromised patients, right? So chemotherapy patients, any of these patients are going to be more likely to see that. All right. So again, when you see a nosocomial pneumonia, like this is something you want to start therapy on as soon as possible. Obviously, get your cultures beforehand if possible, but you don't want to wait for a definitive one. We're going to start with broad spectrum therapy. Again, these are patients who are usually either in the hospital or more likely in the ICU. You need to consider these multi-drug resistant pathogens, and you have to consider covering MRSA and Pseudomonas. These are the two main bugs you want to get, and typically if you can cover those two, the spectrum of antibiotics that you're using is going to get basically everything else anyway, right? Because we're using some pretty big guns here. And then once we have a definitive culture, we have sensitivities, that's when we can start to streamline therapy and start to maybe go down to one drug possibly, or use something that's much more narrow spectrum. That's the kind of the goal here. So again, looking at this kind of pathway here, if you're thinking about hospital-acquired pneumonia, ventilator, healthcare-associated pneumonia, this is where you're looking at late onset, so greater than 5 days, tends to be more associated with those multi-drug resistant pathogens. Looking at prior antibiotics, colonization, sometimes you can actually see patients will be colonized with a particular bacteria. You see this a lot with like our cystic fibrosis patients. They tend to have a lot of respiratory complications, hospitalization, things like that. And then if they don't have any of these risk factors, then you can use more limited spectrum initial antibiotic therapy. We'll talk about what that is in just a second. If they do have these risk factors, right, then we're going to go more broad spectrum. And if it was on a test, I would probably be pretty clear about it. I'd say, hey, this patient has been ventilated, on the ventilator for the past 2 weeks, and they just got off a course of broad spectrum antibiotics a week ago. Which spectrum do you really need to go with, more limited or more broad spectrum? And so you'll kind of have an idea of like where your coverage needs to go to, right? For limited spectrum empiric coverage, if we have this kind of no risk factors, you want to start off with a third generation cephalosporin. It's kind of your go-to. So again, ceftriaxone being a very good agent, or you can utilize something like levofloxacin, moxifloxacin, are possible. Again, if you're more worried about atypical pathogens, this is where you want to go. Again, ceftriaxone won't really cover atypicals. Or you could utilize something like ampicillin sulbactam, right? So it gives us a little bit more broad coverage. Or you could use something like ertapenem. And again, ertapenem is what kind of drug? I guess I already mentioned on the slide. It's a carbapenem, but it's usually kind of much more narrow spectrum than we'll see with some of the other ones. So this is kind of a wimpy one. I usually don't see this one even on formulary in a lot of hospitals, but it could be one option there. However, if they do have some of these risk factors, so those multi-drug resistant pathogens, this is where you need to go more broad spectrum. So again, the more common thing I would see in the ER is you'd have these little old ladies coming in from a nursing home. Again, they would have, previous history of antibiotics. They've had previous hospitalizations, several times in the past few months. These are the ones that are really at big risk for developing these kind of more resistant infections. And so basically what we would do is use gram-negative combination therapies. We're going to use 2 drugs to cover for Pseudomonas and other gram-negatives. So typically we'd use something like an anti-Pseudomonal cephalosporin. Do you guys remember any of those? Cefepime is our go-to for the most part, right? Cefepime is the one that's been around for the longest and is probably the cheapest to get a hold of. Cefepime, you could also use something like what? Yeah, ceftaroline, cetolazine. Again, we don't use those super commonly. It was actually funny. I just had a ER doc who I hadn't worked with for a while. He's moonlighting somewhere, and he's like, "You ever heard of this ceftaroline?" I was like, "Yes, I have. Let me tell you all about it." Right, so cefepime is usually our go-to one for that one, for the most part. Or you could utilize an anti-pseudomonal carbapenem. Do you guys remember any of those? So ertapenem, probably wouldn't go with that one necessarily, but again, not necessarily wrong there. But what's kind of some other ones, some other examples? Meropenem is a really good one. We use a lot of meropenem, and most of the hospitals I've worked in, meropenem's been the go-to, right? Do you remember any of the other ones? There's imipenem. Again, is there any risk with that one? Right. So think about these patients. They're in the ICU. They're possibly getting septic. They're hypotensive. They're not perfusing the kidneys. They tend to be more at risk for kidney injury. And because of that, again, you're obviously going to be renally dosing all these drugs if it's warranted. But they tend to be more at risk for the seizures seen with imipenem. So I really don't see a lot of Premaxin being used there. But meropenem is really good one we see used quite frequently. Or you could utilize an anti-pseudomonal penicillin with a beta-lactamase inhibitor. We have one of those. Piperacillin, tazobactam, right? It's our Zosyn that we're going to go with there, right? So that's a good one. So you need some kind of beta-lactam cell wall active drug to cover your Pseudomonas, and then plus something else that's going to work on a different mechanism, right? It wouldn't make sense to use 2 beta-lactam drugs because, again, they're not going to have any synergy there. There's only so many of those penicillin binding proteins they can work on. So instead, what we can use is something like a fluoroquinolone. So something like levofloxacin, possibly ciprofloxacin. Probably see a little bit more levo being used more than anything else. Or, and what I see more commonly is going to be an aminoglycoside. Yes, ma'am. Because Pseudomonas is such a kind of a risky player. Like if a patient really has Pseudomonas, like you really want to make sure that you're treating that effectively. And because resistance is such a problem, we're saying, well, we're going to use 2 drugs. At least one of these should be active, and we're not less likely to see resistance kind of develop to both of them. So what we end up doing is using 2 drugs to double cover. And again, it's one of those few instances where you double cover for a particular bug. Right? So this is just one of those exceptions.
So are you saying like cephalosporin or the carbapenem or the penicillin plus?
Yeah. So you use basically one of these 3 plus one of these 2. Okay, and that's going to be your gram-negative coverage. And again, with aminoglycosides, I see these used much more commonly. What I see most commonly done is something like Zosyn plus gentamicin, or say cefepime plus tobramycin, or something like that. Those are kind of the most common combinations I see. If the patient cannot receive one of those for any reason, that's when you kind of switch over to some of those other backups, right? And then you're going to need a 3rd drug, and it's going to cover your gram-positives, namely MRSA. So this is where we primarily use vancomycin. Typically see Clinda kind of being left over unless you're worried about anaerobes. You don't see that a lot. And then or Lynnaes lid. Now, of course, if I was worried about like an anaerobic infection causing an aspiration pneumonia for any reason, that's where you can use something like Clinda. One of the rules of thumb that someone taught to me is that if you're worried about covering anaerobes, if it's below the diaphragm, they typically go with metronidazole. Right, remember that was another good anaerobic killer. If it's above the diaphragm, they think clindamycin. So if you're really worried about, a pneumonia there due to anaerobes, clindamycin tends to be a good option. Okay. But again, if you have one of these patients at risk for multi-drug resistant bacteria, this is where we're going to use beta-lactam antibiotic plus either fluoroquinolone or aminoglycoside plus usually vancomycin.
So you were saying below the diaphragm, metronidazole and above clindamycin blood?
For anaerobes.
Just for anaerobes.
Yeah.
Okay.
It's a general rule of thumb. So if you had like a gut, infection or something like that, like, that metronidazole could be a decent option for that. Yes, sir.
Question. In this specific MDR situation, could you use tigacycline?
You could use tigacycline, but the way it was described to me is, one, you want to hold back on that drug because one is bacteriostatic, right? Think about things like your fluoroquinolones and your aminoglycosides and your beta-lactams. Those all tend to be bactericidal. If I'm worried about my patient not really being able, they've gotten that sick to begin with, and they can't really fight off the infection on their own, I want to give them something that's really going to give them the best chances. That's kind of how it's described to me. And also, you worry about resistance developing to tigacycline, so that's usually a backup. So the thing I would normally see in the ICU, a patient who develops, say, like fluoroquinolone resistance, say they started off with coverage for like Pseudomonas and MRSA and all that good stuff, then all of a sudden they came back with like resistant Acinetobacter, right? It was producing Carbapenemases, and it was,
So it's too broad, essentially.
It's kind of too broad in the fact that you want to save that for when you got nothing else, right? So tigacycline can be utilized in those kind of cases, right? And if they fail that, that's when you can use something like, polymyxin, which is like super toxic to the person as well. But, if it's like dead or your kidneys are fried and you're on dialysis, like, I'd probably go with dialysis in those cases, right? That makes sense so far? Okay. Again, I mentioned what are anti-pseudomonal cephalosporins. These are going to be the most common ones. So again, ceftazidime we don't use very frequently due to rapid resistance. We don't like that one. Use very, very sparingly. But cefepime is our go-to cephalosporin there, right? Again, these are all going to require renal adjustment. And again, these patients are more likely to see acute kidney injury due to hypoperfusion and things like that. So really watch their kidney function and make sure you adjust for that. As far as carbapenem, you have imipenem, cilastatin, the Pramaxin, watch out for seizures. Meropenem, much less risk for that, which is why it's kind of our go-to. And then ertapenem really has kind of limited activity against Pseudomonas, so it's probably not the one we jump to, but it could be an option in some rare instances.
On the cephalosporins, is there a reason you don't use the fifth generation? Maybe just expensive?
They're pretty new, and they're still pretty expensive. And then again, it's one of those things where, like, it's I don't know, it's like one of those too good to use kind of things where you're just like, I want to save this as my shiny new toy. I'm going to leave that up on the shelf. Or like, if you think about like, you're making drinks for your friends, like, you keep the Grey Goose up on the shelf. Like, I don't want to use that. Like, these are from my okay friends. My really good friends come along, then I'll use the good stuff. But in the meantime, you just get the Smirnoff or something, Anyway. Okay. Problem is I don't have a problem with alcohol. I just use it as a good reference. Anyway. All right. As far as anti-pseudomonal penicillins, basically you have piperacillin, tazobactam being a really good go-to there. There's another one called ticaracillin, which honestly I don't even mention it very often because I actually have never seen it used clinically. So really piperacillin, tazobactams are go-to there. Again, they still require renal adjustment, so watch for that. And as far as anti-pseudomonal fluoroquinolones, you have things like ciprofloxacin, levofloxacin. Again, these are going to have really good activity against things like your mycoplasmas, your chlamydias, etc. So those are good atypical killers. They also have really good lung penetration. And this is going to be one of the problems you run into with different antibiotics, is that the lungs are typically hard to penetrate as far as drug therapy goes. And so oftentimes we're either shooting for higher doses or we're shooting for just anything we can do to get higher levels of the drug in the lungs at the time. So that's why vancomycin, we mentioned that we do therapeutic drug monitoring for that drug, right? Now, if we're doing it for something like a skin infection, skin's pretty easy to get drugged to. I'll shoot for a trough of 10 to 15 mics per ml, right? Versus if it's a pneumonia, I shoot for 15 to 20, right? I shoot for a higher trough because I know that if I measure that in the blood, if I measure a higher level in the blood, then I should be higher in the lungs as well. So it's kind of like a surrogate marker. You don't have to know those numbers off the top of your head, but just know that the lungs are harder to penetrate, which is why you may see higher doses being used in order to treat these infections. Okay. Again, careful with your fluoroquinolones. You do want to worry about that resistance risk there. And again, those also need to be renally adjusted. So watch for that as well. As far as aminoglycosides go, these are another one we're going to do therapeutic drug monitoring on. Typically, we've kind of moved more towards, because we mentioned these time-dependent or concentration-dependent killers. Yeah, concentration-dependent killers. So before, back in the day, we used to use like Q8-hour dosing for these aminoglycosides. Now we've moved to using a lot bigger doses, just one time a day. And so that allows for the patient to basically clear out all that drug from the system before we give the next dose. So when we measure levels for these patients, we're usually just measuring a trough. And usually you want it to be undetectable, right? So the lab will come back and say it's less than whatever level. That's usually their undetectable cutoff. And so that way we have that post-antibiotic effect, still killing off bacteria, even though the patient can clear the drug and we don't have to worry about buildup of it. Okay. Then again, vancomycin. Again, we're watching for troughs there because that is a concentration or time-dependent killer. That one's time-dependent killer, right? So we're measuring troughs for different reasons between aminoglycosides to vancomycin, but just keep in mind what those kind of differences are. So again, vancomycin, we're measuring our troughs to make sure we're getting good levels, because again, it needs to be above that MIC for as long as possible. Okay. Again, you always want to make sure you're doing it before steady states. That's why we do it for the 3rd or 4th dose there. All right. The Lynnaes being a very good backup to vancomycin, especially if you ended up growing something like vancomycin-resistant Staph aureus, or if it was due oddly to like vancomycin-resistant Enterococcus or something like that. Lynnaes is also good for the reason that it has a PO form available, so potentially if you had them on IV and you wanted to convert them over to PO, because again, anytime you can get rid of lines out of the patient, things like that, it's going to be good from an infection standpoint. That could be one option there. This one is also nice because you don't have to adjust based on renal function. So if the patient really you couldn't get levels set with vancomycin, because again that one is highly renally dependent, this might be a decent fallback, because again it would be all hepatically eliminated, but also very expensive. So again, like to save that. It's kind of again one of those nice shiny toys you don't want to use necessarily. Vancomycin is kind of a run of the mill, kind of a good hard worker, kind of gram-positive killer. Okay. So as far as further therapy goes, so again, you scale back antibiotic coverage. So depending on what the cultures come back as, depending on what their sensitivities are, the specificities and all that, you're going to come back and see, specifically what you can streamline to. We'll always switch to PO therapy if available, right? Because again, that's cheaper to give a pill. It's also cheaper if we can switch them over and get the rid of lines for patients, right? Especially the central lines and things like that. Now, if you have a failure therapy, you have to consider several things. So one, was it just the wrong drugs? Did I have a resistant pathogen that was resistant? Did I not have adequate broad enough coverage? Maybe I wasn't covering for things like Pseudomonas, or I wasn't covering for things like MRSA. That could be one reason. Could be a wrong diagnosis. Pneumonia, not everything that appears to be pneumonia truly is. You can have other things that can masquerade as that. So things like pulmonary embolus, neoplasm. So maybe you're not really dealing with infection in the first place. That could be one reason. And then, of course, you always want to consider possibly secondary complications. So obviously, if we're giving a lot of these broad-spectrum antibiotics, they're more likely to see gut flora being disrupted, and then you can see C. diff, right? So it's a relatively common thing you're going to see after getting broad-spectrum antibiotics. There's that risk that they can end up getting C. diff colitis. So you want to watch about that. Then like empyemas, lung abscesses are also a risk as well. And again, anytime you're having any kind of sequestered area of bacteria within the lungs, like those are going particularly hard to penetrate, and that's where we can use things like surgical interventions and things like that in order to try to get rid of it. So, again, typically treatment 7 to 8 days for the most part. If you have something that's going to be more resistant, or kind of like one of these bigger bugs like Pseudomonas or Acinetobacter, then we shoot for more like 10 to 14 days or so. Right? We want to make sure we really eradicate that infection. All right, so any questions on pneumonia? All right, moving on, we're going to talk a little bit about our tuberculostatics, or anti-tuberculosis drugs. All right, so these are going to be a new group of drugs. Kind of mention these here just because you're more likely to run into these if you're working, especially with like kind of at-risk patient populations. And like, who do you think about as being particularly at risk for getting TB? Healthcare workers are potentially at risk for, especially for being just exposed to it, maybe having a latent infection. Who else? Refugees potentially. Yeah, that's a good one. Who else? Immunocompromised patients, absolutely. Possibly people who travel frequently. Think about like homeless patients as well. Did you say it? I didn't hear you. Listen, I was waiting for you to really speak up, find your inner confidence, and shout it from the rooftop. Just kidding. Yeah, homeless patients and prisoners tend to also be another potential harbinger or harbor of TB. So these are mycobacteria. Obviously, they're acid-fast bacilli, and they have these kind of the reason why this is very difficult to treat is because they have this nice waxy cell coat due to this mycolic acid. It makes it very difficult for drugs to penetrate through this and actually treat the actual infection itself. Mycobacterium tuberculosis is probably the most common one, at least the one we're going to talk about most here. Certainly, there's other ones, especially like in HIV patients. You can see Mycobacterium avium complex or MAC. But with TB itself, tuberculosis, very slow growing, and it can exist in these dormant states for really long periods of time, right? That's why you guys have to get kind of frequent PPDs to make sure you guys don't have any kind of latent infection that's been kind of sitting there and you've been asymptomatic in the meantime, right? Now, what does a positive TB test look like? What type of skin reaction? very red and gets indurated, right? You got to always look for that area of induration. Most people end up having some kind of limited immune reaction to it, so it gets red. But you got to look like, I've seen one of my fellow pharmacy students at the time. He had grown. I can't remember which country he grew up in, but basically he got the BCG vaccine. Has anyone ever heard of that? Yeah, basically it is trying to immunize you against TB, but it also gives you a positive reaction to it because you've developed antibodies now. So when you inject that TB protein basically under the skin, the body reacts to it. And so it looked like a paintball or something that like just nailed them like really kind of point blank range. It looks good to see a real positive test. You kind of know what it looks like. But anyway. So again, most of the antibacterials that we have, they're working on things like cell division. If they're working on things like DNA replication and whatnot, they don't really work so well, right? Because if these cells are not really dividing all that rapidly, it's hard to really treat them, right? That'll make sense when we talk about things like cancer treatment and whatnot. Is that the more rapidly dividing those cells are, the more affected they are by things that can affect cell division. Okay. Again, there's other ones that are fast growing they can be fast growing, but again, TB is the one we're mainly going to be focusing on here. So again, leprosy, MAC, all kinds of different ones that can be formed by different mycoplasma species. There's going to be a little bit of bleed over of the drugs and which ones are effective here. But again, I'm going to focus on Mycobacterium tuberculosis because again, that's kind of the more standard one you're going to see more often. And then these drugs, again, if you just really want to get you exposure to the drugs so you can again apply them to other ones if needed. Okay. It's a huge worldwide problem. We know that it's pretty easily spread. From person to person, and consists of these kind of latent infections for years potentially. And then also one of the big problems, especially with some of these kind of at-risk patient populations, are more likely to see resistant strains. And you think about a normal infection, you think 7 to 10 days, the antibiotics, 10 to 14 days, something like that. How long do you need to treat TB for? Months. Yeah, it's a treat for months and months and months, right? So because of that, if you think about if you're a homeless patient and you have poor access to healthcare, if you have poor access to really any kind of services, how likely are you to be adherent to things like your TB treatment for the next 6 months to a year? Not great, right? So you have people that will start up therapy, they don't stick to it, and then what do you run the risk for? Resistance, right? So we don't want that. So again, that's one of the big problems you run into, and this can be kind of a global problem here as they get spread from person to person, you get more resistant strains. So again, typically what you end up seeing is that the particles get inhaled, they embed into the lung, and then they actually get eaten up by the macrophages, and they form these kind of granulomas, and there they can kind of reside and lay kind of in a dormant state for a long period of time with really no symptoms whatsoever. So again, once you have someone inhale it, they'll sit there, and then for a while, at this point, the person might be able to convert on a PBD test, and they have these latent infections. About 10% of those people can have the ability to activate and have actual true active infection. Obviously, the worse the immune system, the more likely they would have activation there. And again, this is where you see those, coughing, night sweats, weight loss, all those different things. So again, I'm not going to talk strictly about the diagnosis, but just kind of be aware of what type of patients are more likely to manifest with this. Okay, any questions from the first section? All right, so with our TB, as we have kind of alluded to, like this, you have to treat for a long time. So just as an example, and again, I'm not going to ask you specific treatment times necessarily. I'm probably more focusing on like individual side effects, and this is kind of more of a cursory overview, similar to kind of like our initial bugs and drugs sort of thing, like unique side effects, indications, adverse reactions, things like that. But you can see like for TB, if you actually had a full treatment course, you start off with 2 months of this kind of 4-drug regimen. We'll go into more of these on detail individually, but you're going to have Isoniazid plus rifampin plus ethambutol plus pyrazinamide. We'll see these are some pretty nasty drugs in general as far as side effects goes. We'll see here in just a few minutes. And then once you're on that for 2 months, right, to try to kind of tamp down the infection, then you can go on 4 months of just 2-drug therapy, where you'd be on rifampin and Isoniazid, right? So again, 6 months total at a minimum in a lot of cases. You can actually find that you have to be treated for even longer than that. So for instance, just pulmonary tuberculosis, depending on severity, 6 to 9 months, right? HIV patients with TB, 9 to 12 months, because again, their immune system's already tamped down. They're not going to be able to really fight that infection as well. If you had other body parts being complicated with TB, 18 to 24 months, right? Like I can't take a multivitamin every single day. I can't imagine being on 6 drugs for a minimum of 6 months, right? It'd be or 4 drugs, at least for a minimum of 2 months. That's be very difficult. But the reason why we use combination therapy is because with this active disease, if you only use like say 1 or 2 that are active against the infection, you'd run that risk of having more resistance develop here, right? So that's why we use so many drugs to treat this at one time. So first off, you have isoniazid. Again, this is a drug that is going to be working to block that mycolic acid production, right? So by inhibiting that waxy coat, this is going to help the other drugs to become more effective. It's going to have a little bit better penetrance getting into that TB and be able to treat it more effectively, right? This one is going to be excreted as this acetylated metabolite. You're going to find that depending on the patient, and this is going to be one of those things, we'll see this come up in a few other drugs, but people can have this acetylation reaction. They can either be slow acetylators, they can be fast acetylators, and so depending on that, they can have wildly different half-lives for these drugs. So again, a slow acetylator, someone who's slow at this reaction, do you think the half-life would be longer for this drug or shorter? It'd be longer, right? Because they're not metabolizing the drug as quickly. So they can have, a half-life, say, 2.5 hours, versus someone who was a fast acetylator could be down to, like, say, 70 minutes. And so that, again, can change, your steady-state levels pretty significantly depending on the patient, just how fast they're metabolizing it. And that could predispose them to certain adverse reactions, as we'll see here in just a second. So again, this ends up being kind of metabolically activated by an enzyme from the mycoplasma, and again, this could be another site for resistance, right? So if they alter this enzyme, maybe you never activate the isoniazid to begin with. Other things. Things like that. Basically, isoniazid has good penetration, though, it's well absorbed, so that's why it's good, especially if you have any kind of like CNS complications from TB. This is another really good one to use. So. Sometimes for prophylactic use, you can actually see therapy used alone. So in case you had someone who had potential high-risk exposure to TB, say like a healthcare provider, say you're exposed to someone, and then all of a sudden they say like, oh yeah, you find out later on, it's like, oh, by the way, they had TB. Okay, well maybe you need prophylactic care now. But for active disease, you're typically going to use this in combination. Adverse effects. Now, you see this lupus-like syndrome, and this is going to be more with the slow acetylators. The people who are not metabolizing it very fast, and so when I say a lupus-like reaction, usually when you think of lupus, is anyone familiar with that? Butterfly rash is kind of one of the big things you're going to see there. So again, this kind of vasculitis you can see that'll form on the face. There's a couple other drugs we'll talk about that kind of do this similar reaction. You see that. You can see definite hepatotoxicity associated with it. This is going to be more for patients, especially who have chronic alcoholics who've already kind of have chronic damage done to the liver. See this with increased risk with age. So you got to be careful with that. So hepatotoxicity, you'll be monitoring LFTs. Now, what's also interesting is you can see this peripheral neuritis that forms, and this is because basically isoniazid is going to interact with pyridoxine and actually cause a pyridoxine deficiency. So it's very common you're going to give vitamin B6 or recommend B6 along with isoniazid for your patients to prevent these. All of a sudden they'll have these kind of neuritises and neuropathies that they're starting to complain of. What's interesting. This is actually structurally related to rocket fuel, or hydrazines, essentially is one of the structures there, which is also related to a particular type of mushroom. I know this is very odd kind of information, but it comes from a tox perspective. So you ever thought, drugs, rocket fuel, and mushrooms are three things that would never associate with one another, but it comes up here. Sounds
like fun.
Yeah, a lot of fun. You guys would love my parties. Anyway. So basically what's interesting is because it interacts with B6, this also means it's going to, one of the things you need in order to form GABA, and you guys remember what GABA was? Kind of that major inhibitory neurotransmitter, remember? Right, it's like this is what the thing that keeps us from seizing at any given moment, right? If we have, make sure we have enough GABA to prevent those action potentials in the CNS from firing too much, causing a seizure. Because it interacts with B6, you can actually end up having a GABA deficiency, and so you can end up having kind of these intractable seizures as kind of one risk. So again, seizures, neuritis, like these are all related back to this B6 deficiency, essentially. We had one really interesting tox case where these guys in kind of the panhandle of Florida, kind of middle of nowhere, they loved to like race some kind of, they weren't like some sort of go-karts or something, but they were basically using hydrazine fuel for that. I guess these little rocket-powered go-karts or something, like, didn't get too much into it. But basically, what they ended up doing is accidentally had an unlabeled bottle that had some of this fuel in it that was hydrazine-based, accidentally took a swig of it, ended up having these intractable seizures related to B6 deficiency. So we had to give them like a 5-gram dose or something IV. Actually, some of that energy drink that you guys were drinking probably would have come in handy. Would have like 6 million% your B6 requirements. But yeah, so take your Zip Fizz or Isoniazid and you should be okay. Shouldn't see any of these side effects there. But yeah, so again, it could be one thing to watch out for. Also, some people actually have tried to abuse Isoniazid before because it can cause some euphoria. I would not recommend it, but some of you have tried that. Anywho, We also have rifampin. Rifampin is really, really important, and this is going to be important when you think about drug interactions. This will come up again when we talk about endocarditis in the cardiology section a little bit, but it's pretty broad spectrum antibiotic, has good coverage against things like Neisseria. So think about like meningitis. Sometimes you'll have patients on rifampin for that. Some Staph aureus, some Legionella, and also we'll have some good broad spectrum gram-negative coverage here. But again, the big thing we like is it affects TB. So this is actually going to inhibit. So once you have isoniazid come in and kind of disrupt that waxy coat, you can have rifampin come in and affect the the RNA polymerase, and actually form this complex there to where you cannot continue to form new RNA essentially from the mycobacterium DNA at that point. Now, we don't use it by itself because you end up having rapid resistance develop with it. So again, that's why you usually use it in combination with one other drug at least. And the primary place we're going to see this is with tuberculosis. Occasionally, you may see this used for meningococcal disease as a prophylactic. Actually, we had a case at Nemours several months ago where a kid came in, actually had Neisseria meningitis related meningitis. Patient ended up passing away, unfortunately, but everyone in the ER who had direct care for that patient, because they came in with no mask on, we didn't know what it was at the time, we had to receive prophylactic therapy. And we used to use rifampin a lot. Now I think we use like a dose of Cipro or something instead, but neither here nor there. But meningococcal disease, you may see that, and then also for endocarditis. Those are the primary places you're going to see rifampin being used. Does anyone know what color rifampin is? Red. Yeah, it actually turns a lot of your color of your secretions red. So adverse reactions. Mentioned secretions, kind of more of an orangish kind of color depending on the dose and on the concentrations. But your tears, your sweat, your urine can all come out kind of reddish oranges. Again, that can stain clothes and things like that. So you need to educate patients about it. The other big thing, this is inducing P450 enzymes. This means that it is rife with drug interactions. It induces CYP1A2, 2C9, 3A4. That means it's going to be affecting your anticoagulants, contraceptives, digoxin, theophylline. All these different drugs get affected by rifampin. So it's super, super important. You look for drug interactions. And again, think about, patients who are immunocompromised are more likely to get a TB infection. So think about like an HIV patient. Think about the drugs they're on, right? Those are also, when we get to the HIV section, you're going to realize that their drugs cause a ton of drug interactions and can all be affected by this as well. So again, it can be very, very dangerous if you don't know what you're doing when you kind of mix and match these kind of cocktails of medications for those patients. And then some patients will have kind of a hypersensitivity, kind of flu-like reaction to this, and then some GI disturbances. Also a little bit of hepatotoxicity, but again, the drug interactions are the big thing, and then also the changing the colors. Anytime you change the color of someone's urine or their feces, it's good to educate people because they get pretty freaked out otherwise. All right. Up next, we have ethambutol. Again, this is going to be used more in that early active treatment phase during that 4-drug regimen. Again, this is going to be probably working more on the mycolic acid incorporation into those membranes, but we don't know the full effect of its mechanism essentially. But no effect on any other bacteria, so this is really the only place you're going to see ethambutol being used. Again, by weakening that cell wall, though, it allows for better access for the other medications, things like rifampin. So this has to be renally adjusted for, so watch out for that. And then again, we don't use it by itself because resistance can be pretty significant there. Big thing we see with adverse effects, though, is you can actually find some visual disturbances. These are typically limited to children for the most part. But you can see things like decreased red-green discrimination, so you can't really tell the difference between those colors quite as well, and decreased visual acuity. May or may not be reversible, again, depending on how long they're on it for. This might be one of those things that, again, you kind of do an initial kind of visual acuity. You're kind of looking for any kind of changes as time goes on as they're on it. And obviously if there are any changes, and you may need to switch to a different drug. Okay, and also maybe some risk for uric acid levels to go up. Maybe see things like nephrolithiasis, things like that. Next up, we have pyrazinamide. This gets converted over to pyrazinic acid and actually lowers the pH, so the bacteria doesn't actually grow. So as it gets entered into the macrophage, it actually kind of stunts the growth of the mycobacterium essentially. And again, this is good because when we add it into combination with the other drugs, it actually shortens the combined duration of therapy, which is good. And I mentioned you get the first 2 months only, and then you kind of fall back and just using isoniazid plus rifampin later on. Again, nothing too crazy here. Again, just look for LFTs. You're going to be monitoring that anyway, especially with the isoniazid, and this one would be avoided in pregnancy. Okay, so as I mentioned, sometimes you can see combined therapy. If the bacteria comes back resistant to either rifampin or isoniazid, you end up having to treat for up to 2 years in some cases. So again, very, very long treatment times here. This is why in a lot of cases, you guys ever heard of direct observed therapy? You know what that is? It's just like what it says basically, but it's kind of a program where do you have TB? Just checking. Basically, with direct observed therapy, the patient actually come into the clinic. You'd actually watch them take it, and that way, they're usually coming in for other services as well. So it's kind of one of those things that kind of helps to enhance compliance because you're actually watching the patient actually take the drug. There are other agents we can use, and I'm not going to necessarily quiz on these specifically, but just know other drugs may have activity. You may see some altered regimens depending on resistance, things like Lynnaes, rifabutin, which is very similar to rifampin, macrolides, and things like that. Okay, so just kind of a, yes, ma'am.
The direct observation therapy, is that only in the resistant ones, or that's just all?
It depends on the patient, right? So if it's like, someone who, like a homeless patient doesn't have really good follow-up, things like that, if they're coming in to a clinic for, say, other services, to be rendered, like this is a good time to try to initiate this sort of thing where you're kind of watching them take it. But if it's someone who's, otherwise you don't have a lot of worry about them being compliant, then they wouldn't necessarily need that, right? So it's all going to be dependent on the patient. I'm not trying to pick on homeless guys, but those tend to be the reason why you see a lot of resistance develops, because again they may not be compliant, because again if they don't have really good access to care, things like that, they just tend to be ones that fall off the map essentially. Anywho, as I mentioned, there's other types of mycobacterium infections. MAC or MAC, Mycobacterium avium complexes, tends to be one you see more often in HIV patients. It tends to cause pulmonary disease, and again 10 to 40% of HIV patients, especially as their CD4 counts start to drop lower and lower, you tend to see more and more of this. So especially one of the interesting things with HIV patients is that you monitor their CD4 count, and depending on how low they get, that's when you kind of initiate certain therapies, either as prophylaxis or as treatment, because they tend to be more at risk. So this is one of those ones where if they get below 100 cells per millimeter cubed, you basically end up starting some prophylactic therapy against MAC, because we already know they're at higher risk, right? There's other cutoffs for different ones, as we'll see when we talk about HIV, probably in Pharm 2. But again, here you're going to see that we use kind of similar drugs. You can utilize some macrolides here, things like clarithromycin. Thiambutal is going to show up here again because it has activity against mycobacterium. And then here we might actually use rifabutin as a counterpart to rifampin. You kind of think of those two drugs very synonymously with one another. Again, both inducing CYP450, so you got to watch out for those drug interactions. And just some other alternatives you can possibly use. Again, long treatment times for these because they're so slow growing. Anytime you're using something that's affecting things like cell division, it can take a while to really have these have effects, right? So again, 4 months, at a minimum. Okay. And then this is one, if you ever see like an HIV patient who's on, say, like a azithromycin or clarithromycin, typically they're on that for prophylaxis against MAC. Again, we'll talk more about that later in Pharm 2, but just be aware if you ever see that, that's probably why they're on it. It's not because they're actually treating, say, some other type of pneumonia or something. They're generally on it for prophylaxis. Okay. Yes, ma'am.
So would the drug of choice for this be the rifabutin?
It's going to be one of the drugs you're going to use. Like I said, I haven't seen too many actual cases of it being treated, but certainly I see a lot of prophylaxis. Yeah, this is one of the things, if you ever saw a patient who's like on azithromycin every day with like no stop date on it, then that's usually what it's being used for. Yeah. Okay, so moving on to something I find a little bit more exciting, anaphylaxis treatment. Again, I kind of add this in the pulmonary section because it's one of those things where the pulmonary complications of anaphylaxis are pretty significant, obviously, and so there wasn't really a better spot to put this in, so I said, no, let's put it here. Anywho, so the anaphylaxis is going to be kind of a severe systemic allergic reaction, right? So certainly can be to lots of different things, peanuts, shellfish, whatever, bee stings, whatever you can think of. You can have a potential anaphylactic reaction to. And again, when we see severe cases, you can see complete obstruction of the airway, cardiovascular collapse, and death can ensue. Obviously, lots of different types of substances. Again, medications can certainly be a big one. Again, that's why you need to do a really good history to try to figure out, okay, what have they been exposed to new recently? Maybe they've not been exposed to previously. It could be related to this. Super in depth on that. Obviously, the way that you treat this is depending on how severe their symptoms are. So obviously, airway compromise is like obviously the biggest concern, in cardiovascular collapse. And so you're gonna be looking at things like, what's their blood pressure doing? What's their heart rate doing? What does their lung exam sound like? Typically, you expect their heart rate to do what in these sort of cases? Maybe tachycardic, bradycardic, probably tachy. And what do you think their blood pressure is probably doing? Be hypotensive, if anything, right? And so again, usually that tachycardia is in kind of response to that vasodilation is happening because again, due to which mediator? Histamine, absolutely right. So again, we're seeing our antihistamine starting to come back into play here. Right, when you have that massive degranulation of all those mast cells, that's when you start to see histamine causing massive vasodilation. The heart's trying to keep up with that by trying to beat harder and faster, and that's where you get that tachy, hypotensive kind of look, right? It's kind of that shocky kind of looking picture you see with those patients. Certainly you can see some GI effects here as well, because again, histamine doesn't know whether it's affecting H1 or H2 receptors, so certainly you can see some nausea, vomiting, see kind of hypersecretion in the gut as well. You can all see that there. Some pictures of people with an anaphylactic reaction. Now, this is not to be confused with angioedema. Has anyone ever heard of angioedema? What do you see that associated with? Yeah, they get a lot of massive like lip and tongue swelling. It's not really the same reaction they're having here. Does anyone know any drugs that cause angioedema? Yeah, lisinopril or ACE inhibitors in general can cause that. So again, it's a little bit different reaction. A lot of people end up treating it the same way because you think, okay, they're the throat swelling, their tongue's sticking out completely out of their mouth. Like it seems very similar. We'll talk a little bit about the differences there when we get to talk about the antihypertensives. But again, typically these are what your patients are going to look like. So the first thing you're going to do, these patients, and this may have been handled by EMS coming in, but typically the first thing you're going to do is volume expansion, right? Especially if they're hypotensive, if they're tachycardic, you want to get some fluids into them, okay? We'll talk more about fluids probably later on at some point, but again, most of the time we're going to use what we call an IV crystalloid. Does anyone know what I mean when I say crystalloid? It's salt-based, right? So basically, sodium chloride is going to be the most common one we're going to use here. So sodium chloride, or what we call 0.9% sodium chloride. Does anyone know another name for this? Normazoline, as I like to call it. If I have patients I'm worried about drug seeking, I'm like, let me give you this really good drug. It's called Normazoline. You'll love it. But yes, normal saline, right? We call that because normal saline is roughly isotonic with the blood itself, right? So it's has a roughly 308 milliosmoles per liter, and the blood can be anywhere between 280 and 320-ish. So again, it's isotonic, which is good because it helps to fill that intravascular space. We'll talk much more about that later on at another point in the class. But this is good because it's going to help to tank up the intravascular space. It's going to help to slow down the heart rate, hopefully, and helps with that blood pressure and also perk that back up. So these are good numbers to have, and this is why I kind of go over this early in the class, because I kind of want you guys to internalize these numbers and to know them, because it's going to come up very frequently in your career. You're going to ask, well, how much of a fluid bolus should I give, or what should their maintenance fluids rates be? And you're never going to go wrong as long as you know these numbers. Okay. In general, for a fluid bolus, when I say bolus, basically what does that mean? Give a big dose all of a sudden, all at once, so I can try to kind of tank them up kind of immediately. I fill that intravascular space. 20 mLs per kilo is going to work for most all your patients, especially for pediatric patients. 20 mLs per kilo, right? That usually equates for adult patients around 1 liter to 2 liters. Okay, and these questions on dose, because I want you guys to know these, like it could come up on the test, right? And again, the math will be very easy. You won't even need a calculator, I guarantee. So again, if you have a patient who comes in and say they are, 40 kilograms, how much of a bolus should they get? 800 mLs, right? Because again, we're going to do 20 mLs per kilo, so you just do 20 times 40, you get 800 mLs. Now again, typically you're going to top it out around 1 liter to 2 liters for an adult patient, as I mentioned, because again, you can always give more, but the thing with fluids is once you give it, it's there. You can't really take it back, right? And then only time you ever drop this down, especially if you had a patient who was already kind of edematous to begin with, or maybe they had renal dysfunction, you could do 10 mLs per kilo. But for most healthy patients, because again, otherwise, most of those patients with anaphylaxis, they're otherwise healthy, right? As long as they don't have any kind of pre-existing conditions. But generally 20 mLs per kilo is good for most patients. Okay, so that's your fluid bolus. You typically run that in pretty quickly, say 10, 20 minutes, 30 minutes, maybe run that in. And you'll find these patients are, especially when they're really profoundly hypotensive, they could take 4-8 liters just to kind of fill that intravascular space, because those blood vessels are getting very leaky. They're very vasodilated. It can take a lot to really fill them back up. So just be aware, you may need a lot of fluid there. And then you want to put them on a maintenance fluid rate, because again, you want them to kind of be just have a nice maintenance fluid rate. It's going to keep the IV line open. It's going to make sure they are replenished with fluids, because again, they're probably sweating, they're probably losing a lot of fluids through urine and different things like that. We want to replace that. And so what we have here is what I call the 4-2-1 rule. Have I mentioned this before? Okay, so we've already covered this. Good. So you guys remember the 4-2-1 rule. So that means for the first 10 kilos, how much I get? 4 mLs per kilogram, right? So that means if you had a 10 kilo kid, I get how much? 40 mLs per hour, right? So that's your maintenance rate, because again, you got to keep your units straight. For the second 10 kilos, you get 2 mLs per kilo per hour. So if I had, say, a 20 kilogram child, what would they get? They'll get 40 for the first 10, and then we get 20 for the next 10, so they get a total of 60 mLs per hour. Absolutely. Okay, so we got 60 mLs per hour for that 20 kilo kid, and then for every subsequent kilogram, 1 ml per kilo per hour, right? So say, for instance, if I had an 80 kilogram patient, what would I give them? So you get 40 for the first 10 kilos, get 20 for the next 10 kilos, and then how many kilos do I have left over? There's an 80 kilo patient. Yeah, so you have 60 left over, so 60 times 1, you have 60. So basically it's 60 plus 60, 120 mLs an hour. Practice with this, get used to it, right? Because again, when there are rotations out there, you're going to look like rock stars if they can say, like, hey, how much fluid should I give this patient? It's like, hey, give them this bolus, put them on 100, 100 mLs per hour, and you'll just be able to rattle it off no problem, right? You guys look awesome. That's really the goal of rotations, and I try to make you guys look as cool as possible. Go ahead, because I never could when I was on rotations. Yes, ma'am.
So there's not, for the bolus, there's not a different consideration for peds versus adults?
That's the nice thing about that 20 mLs per kilo is it kind of works for everybody. So for a 1 kilogram newborn, 20 mLs per kilo. For a 90 kilogram, adolescent adult, 20 mLs per kilo. You can't really go wrong with that, which is nice.
And again, back to does obese or muscle weight have anything to do with that?
Not a ton. Again, you're kind of evaluating your patient. You're going to see kind of what their blood pressure is. What do they look like they're edematous? Do they look like they have a lot of fluid overload on them already? If they don't, then you can go ahead and stick with that number, right? So I think about renal patients who are on dialysis. I'm probably only going to give them 10 per kilo, right? It's kind of what we call a half bolus. They have, if they're coming in for a CHF exacerbation and they're already kind of edematous, but they're hypotensive, I may only give them 10 mLs per kilo because I can always give more. Can't take it back once it's in, though, right? Okay. Again, so be aware of that. Know how that works. It's going to come up on the test again, right? Because again, I think it's one of those kind of fundamental things that a lot of people just don't know when they go on rotations, and it's easier to learn it now than it is later on, right? Okay. Next off, the next drug we're going to give epinephrine. Everyone should be aware of epinephrine, right? We use it all the time in our bodies. Anyone ever heard of someone having an epinephrine allergy? So if someone said, I have an epinephrine allergy, I can't receive epinephrine, what would you say to that? You're a liar. That's not very nice to call your patients. Think about the fact that drug products don't just contain that drug. Think about things like preservatives. Think about things, other inactive ingredients. Sometimes what you'll find with epinephrine actually comes with sulfites in it in order to preserve it, because epinephrine tends to be a very kind of volatile kind of chemical. But the sulfites, a person can have an allergic reaction to that, and so that's actually one of the reasons why someone could say I have an allergy to that, or if they say I have an insulin allergy. That sounds like BS, but then actually they can have a reaction to one of the inactive ingredients actually contained within the insulin products. Always think about that when you hear someone with a kind of off-the-wall kind of allergy. Okay, so the big benefit of giving epinephrine is it's going to be affecting both alpha and beta receptors. It's going to be kind of a balanced effect here. So the alpha effects, we're going to see a lot of vasoconstriction. We're going to decrease that vascular permeability. This is going to be the big thing that we're focusing on as far as effects on the cardiovascular side. But then the beta effects, what's it going to do to, again, if you think about the lungs, which beta receptors do you think are predominantly there? Beta 2, right? We activate beta 2. What does that do? Bronchodilates, right? That's a big thing because again, these patients are going to be wheezy. They're going to have stridor. They're not going to be not really aerating very well. By causing that beta 2 activation, cause bronchodilation. Okay, so that's another big thing you're going to use. It helps to alleviate some of the pruritus, urticaria, the angioedema. It can help to fix kind of all those issues there. So I'm sure everyone's heard of an EpiPen. Right, that is basically an auto-injector of epinephrine that a person can give themselves, basically. So typically, if you have someone who has a history of anaphylaxis, one of the big education points is always going to be you need to carry this around with you at all times, because again, you never know when peanuts can strike, right? Very sneaky, those peanuts. But you never know what's going to be like contained in a food product, or you're just not aware of something being, if you have a shellfish allergy, like there's lots of products that actually contain shellfish in them you might not think about. So. A good education point, always carry that stuff around with you. Typically, we're going to give this intramuscularly unless the patient is coding, and at that point, we can switch over to use IV therapy. Giving epinephrine, you're going to feel pretty crummy, kind of having like your sympathetic nervous system kind of kicked in overdrive all of a sudden without you really having a true fight or flight response. So it doesn't really feel good for the patient. So IM is typically preferred there. One of the big things that we run into with epinephrine is actually drug errors, right? Because of the fact that concentrations were not standardized for a long time. Basically, they'd have this nomenclature that say 1 in 1,000 versus 1 in 10,000. If you saw that, what would you think about that as far as concentration? What does 1 in 10,000 mean? More dilute than maybe like 1 in 1,000. That's a reasonable assumption. Yeah, basically it was saying that that's 1 gram in 10,000 mLs, or 1 gram in 1,000 mLs. You know, so 1 to 1,000. That's not super useful for our purposes, and so they've been moving away from this pretty significantly. So now most of the products are actually going to come 0.1 milligrams or 0.01 mil, or whatever happens to be per ml, which is generally a good thing for us, because again, we're running issues where you have a tenfold overdose or underdose potentially, and that could lead to things like cerebrovascular accidents, because you basically constrict way too much in the CNS, causing strokes essentially, or you're giving too little of a dose, and then the patient's not really getting any benefit from that. So that's one of the big things. So I probably won't test on this specifically. Just know they're kind of moving away from this, and so it's really important to watch what form you're using, because again, we typically use the more concentrated form for IM use, so that way we can give a much smaller dose. Basically, for like an IM administration, we're using a 1 milligram per ml concentration. That means that, you know, for a typical adult patient, they may get like 0.3 milligrams. It's a very small volume to inject intramuscularly, which is good, because again, one of the big issues with giving large volumes in the muscle is what? Hurts real bad, right? So that's why we don't want to give large volumes of drug to the muscle, because it's very painful. But if we're using an IV, then we can utilize a more dilute concentration, because again, we can kind of titrate that dose a little bit better. So that's kind of one of the big things you'll see. Obviously, as far as adverse effects go, anxiety, hypertension, worsened tachycardia, diaphoresis, basically their whole sympathetic nervous system is going to be kind of being activated by this drug that you're giving to them. So just be careful, especially patients with cardiac histories. You can worry about seeing like MI, especially if you cause constriction of those coronary vessels. Okay. Are we out of time? Do you have any time left? I can't tell when we started. I think we started at 10 minutes. Let's do that. This section real quick and we'll be finished up. All right, so histamine blockers. This is another big component of anaphylaxis treatment. Again, if they are really coming in and they're having, they're hypotensive and they just look sick as snot and their throat's closing up, like, yeah, epinephrine is going to be one of the first drugs you're going to give them. On the other hand, though, if they come in and they are less severe, right, they just complain of a lot of itching, maybe they're having a little bit of tightness in the chest and they're just complaining a little bit of difficulty breathing, you may not jump straight to epinephrine. Maybe you'll start off with something like one of these antihistamines. Again, the big receptor we're going to be focused on is H1, right? Because again, this is associated with those allergic reactions we see there. So we use a lot of H1 blockers, and this is where we can use IV H1 blockers like diphenhydramine or Benadryl is really good. Hydroxyzine or Atarax is another good one that we can use potentially IV. This is good because it helps relieve that rash, pruritus, the hives, or a lot of the cutaneous effects can be kind of alleviated with this, which is good. Some people will recommend using H2 blockers like ranitidine. We'll talk more about that in the GI section because, again, you worry about some of those GI effects. It's kind of a plus or minus kind of thing. Some people use it, some people won't. But just know if you ever see someone getting like Zantac, it's not because they're having GERD necessarily, but it could be related to those GI effects from the anaphylaxis. And then also you're going to be administering bronchodilators, so you can not only be giving more systemic epinephrine, but you can also give a bronchodilator via the respiratory tract to try to help with that bronchodilation. So we'll talk more about this in the asthma section. You have things like albuterol, which is a beta-2 agonist. Again, so directly affecting beta-2 receptors causes bronchodilation, which is good. Other adverse effects, we'll talk more about this in a little bit, but you can see things like anxiousness, tremor, tachycardia associated with that. Because we say it's a beta-2 agonist, but does that mean it's 100% selective for that receptor? Not necessarily, right? So it all has to do with dose, and so it's one of those things where the bigger the dose you're giving, the more likely are to see some crossover, some bleed over, and affect the beta-1 receptors. So I was a nerdy fat kid growing up with asthma when I was growing up, and so it was before we really had a lot of long-acting beta-2 agonists that were used. So I had to use a nebulizer, right? So instead of if I had a really bad cold or something, I had to use a nebulizer. And so the thing with that, you guys ever used a nebulizer or seen one? Basically, you take the drug and you put it into a little cup, and that cup kind of vibrates it at a high frequency, and it generates a mist, essentially, that you're breathing in. You're breathing such a huge dose by that by the time I was done with it, and if anyone's ever experienced this, they'll know what I'm talking about. Your heart's racing, you're super tremulous, and you're just like, you're just kind of on edge. Versus if you use something like a smaller controlled dose, like an inhaler, you get a very small amount that is going to be a little bit more targeted, essentially. So just be aware those are kind of the typical side effects you can see from albuterol being administered. The other big component here. So again, most of those drugs we kind of talked about, how fast do you think they're working? Pretty quick, pretty slow, pretty fast, right? They're directly working on those receptors, directly affecting alpha, beta, H1, like pretty quick. Corticosteroids, though, while powerful in decreasing this inflammatory reaction, are going to be a little bit slower, right? Because again, they're not working necessarily on any particular receptor. They're having to get into the nucleus and starting to change that transcription of proteins and things like that. So it takes a little bit of time, but they're very, very powerful at blocking these allergic reactions from kind of the top of the inflammatory cascade down. This is going to work on all aspects of anaphylaxis, but it's going to take time, several hours to work. But the things we're going to be giving are usually, if it's more severe, we'll give an IM or IV corticosteroid like methylprednisolone. Or as an alternative, we could potentially use oral if it's kind of less severe. We can use something like prednisone, dexamethasone. Any of our corticosteroids we've mentioned previously can work in this regard, right? All of it is a matter of dose because they have a little bit of different potency between one to another, essentially. Okay, so that's it for that section. Do you guys have any questions? Then we'll go ahead and cut it there. Give you guys a few extra minutes. That'll be nice. Any questions, concerns, comments, quibbles, quips, quotes? All right, I'll see you guys next time.